Hello, this is Fernando Gomez Sancha, and this is the first video of the year 2023. I have been a little bit busy, and it's getting difficult to have the time to prepare these videos. Also, we have some technical problems with the ability to record in the operating room, so I have to, edit the video and put some voice to it. And it takes some time. But this is an 85-year-old gentleman who has a 90-gram prostate, something like that. And I thought the case was nice because I was having a colleague standing by me, and I was trying to explain the procedure to him. So I think there's some features of this video that are probably nice to make some points that are maybe quite useful for people who are learning and trying to improve their en bloc technique. So here's the white line. As you can see, I have marked the white line, and now we're going to enter the planes. I think the procedure is getting, in my hands, more and more systematic, and I tend to do always the same, always the same, always the same. And that helps a great deal. This is the entry into the plane. I think this is something that you have to start doing without hesitating too much. I see a lot of videos of people who take a little while to enter the plane. I think it's very simple. If you put your fiber in the floor of the veru, lateral to the veru, but right down to the floor, and then you start moving in and out laterally like this, you will enter the plane very nicely and very fast. Then if you cut the midline on top of the verumontanum, then when you cut the frenulum, you will have the posterior line of dissection. And this is what we have now. And as always, the scope should look or try to keep the line of dissection in the center of the image, so we can see a little bit of capsule and a little bit of adenoma. And the fiber is moving widely from side to side. You don't want to do little holes, little dissections. You want to go from side to side with these ample movements to get very broad lines that will allow you to understand the plane a little bit better. Lately I'm telling everybody that looking for the beautiful plane, sometimes it's not easy, because there's not always a good plane, and there's not always beautiful, and sometimes you don't find it. So I don't try to find a very beautiful plane. I try to find a capsular plane, which is defined by a number of things. Here, this is the entry now into the lateral plane. So you see, what I want to do is to do a little bit of entry into the lateral plane. I don't want to do a very sudden dissection of the lateral plane, but just a little bit, near the sphincter. I try to go, sorry, this is some manipulation of the device. I try to do a little bit of dissection, like 4, 5, 6 millimeters near the sphincter, and then take this dissection towards the bladder neck, maybe about halfway towards the bladder neck. And this will mobilize the apex, and also it will help us to connect the lateral line with the posterior line. Here, this is the mucosa of the sphincter. I always do these access incisions initially, so you want to cut a little bit. It doesn't matter if you cut a little bit into the adenoma. These access incisions initially are vertical, like here, you see, and then as you go more anterior, they start to rotate or change direction to become more horizontal. And then again, we're going to gain a little bit more of the lateral plane. So here you see, I try to go up and down like that to gain a little bit more dissection, and always connect the line, because the lines are super important. If you have a nice posterior line that is showing you, the depth of the interface between capsule and adenoma, and then you mobilize a little bit the apex, you see the distance that you create between the adenoma and the capsule allow you to enter this anterior zone with better access, better mobility of the apex. As I said before, this is now quite horizontal because the sphincter is right above us, and initially you have to cut a little bit horizontally like this to find the good plane and to follow, because we are doing an ascending dissection on the lateral aspect on the right side of the patient, and I'm trying to construct the line of dissection of the lateral plane. So you see this line is formed by the convergence of adenoma and capsule. When you approach the edge of the dissection, you find this line. And here probably I was doubting a little bit if the depth of the dissection was okay. So I was showing my colleague, if you are in doubt, sometimes you can do a little bit of mechanical dissection. Here we see the beautiful plane, you see. But the thing is with these new energies, when you try to dissect the plane, it's going to be altered by the energy. It's going to be coagulated. It's going to be, more difficult to keep seeing the beautiful plane. So you have to stop thinking about the beautiful plane and start thinking that you want to learn to distinguish what is a capsular plane. Now we're going to do the same on the other side. Here you see I'm deepening the white line a little bit. Here you see, because I want to enter the lateral plane. And it's only 2,453 millimeters. What I need to start developing the lateral plane. You see, we had a very nice posterior line. And now you see, going up and down like that, I'm going to mobilize the apex a little bit and connect the lateral line that I'm creating now with the posterior line. Again, exactly like we have done on the other side. And this is what I mean when I say that I'm trying to be always very systematic. I always do the same, and it seems to work really well for all kinds of prostate sizes and situations, also for the redo cases. So, but before ascending with the dissection, we have to make sure that the apical part is released, because if you release the apical part first, when you go up with your scope, you're not putting tension in the sphincter. You're not damaging the sphincter. So this is the principle. You liberate first the most distal part, and then you continue the liberation towards the bladder neck, trying to construct a line that you can recognize and a line that you can then connect, you see, with the posterior line. So here again, you see, mostly in this part of the operation, the fiber is pointing against the line. This will change later because the capsule now is quite parallel. The direction of the capsule is quite parallel to the fiber, so there's very little risk of perforating in the beginning of the operation. So you see here I come again towards the apex because we have to cut the apical attachment first. Here I'm trying to keep horizontal. We are in the white line, but we know that the sphincter is right above us, and you can see a little bit of mucosa on the left side there, that represents that we are right at the white line level where we marked before. And here I'm trying to carefully liberate most apical part, so then we can progress with our dissection toward the bladder neck a little bit more. So you see that it's like having to take a ladder with some steps. The first step is 4 or 5 millimeters to start the lateral line, and then we take another 4 or 5 millimeters and we dissect towards the bladder neck. But we always come back and return to the apex to check, you see here. And the nice thing is that when you have passed from the lateral to the anterior line, which sometimes happens just like that, you see the adenoma falls a little bit, and then the 12 o'clock fibers are shown, are exposed. You see there is some space between the adenoma and the capsule at the top, and now we can easily cut the 12 o'clock fibers. So that's my favorite approach, to go and dissect the lateral plane on one side, then the lateral plane on the other side, And then when the tip of the adenoma is descending, because we have liberated the attachments to the anterior capsule, then it's easier to try to cut the 12 o'clock fibers. I think you have to be careful here to, of course, to protect the sphincter, but also to go up and to be aggressive going up 12 o'clocks, because we don't want to leave a lot of tissue there. Okay, sometimes you see the capsule looks a little bit flimsy there, and there you have to be careful with your targeting. You don't want to make a hole in the capsule, so you have to target your fibers so that it continues developing the plane as safely as possible. So you see, now we have a line that goes around the adenoma that we can follow all around. You can follow lateral planes, we can follow anterior plane, and we can follow posterior plane. So now the apical liberation has been completed. Now the sphincter is totally separated from the apex, which causes us a great relaxation. You know, we're not fearing that the sphincter is going to be damaged during the operation, as I used to experience when I did the three-lobe classic technique. You know, here the nice thing is in the first 10 minutes, it's 11:20 now, you have released the sphincter, and then you can concentrate on a careful dissection of the adenoma circumferentially. Okay, so here, you know, everybody asks about the settings I use and what settings, and the settings are going to determine how the energy is coming out of the fiber. But the main determinant of how the energy reaches the tissue is the surgeon, because you can play with the working distance. You know, if you fire too far, there will be no effect. If you get closer, you will see some coagulation effect. If you get even closer, then you will see some disruption of the plane. And then, of course, if you touch, then that will be the most disruptive. You see here, I'm coagulating by separating the fiber a little bit. If you get closer, it gets more disruptive. So the surgeon has to handle the fiber at a distance that produces the desired effect. And I think for the development of the plane, it's very nice when you have an effect. And as you see here, I was probably explaining things to my colleague. You want to choose the effect that is going to give you the feedback. You know, you're going to see what effect you're getting in the tissue, and then you modulate the distance of the fiber and the tissue to get the effect you want. Of course, another aspect which is paramount is the speed of movement of the fiber. You see the fiber dissects when it's moving. So if you move too fast, maybe you will realize that you're having a nice dissection of the plane, but the hemostasis, the first pass hemostasis, is not very good. So you have to find a balance, and this is a very difficult balance. I often, you know, get carried away with the dissection, and I forget to do, you know, careful hemostasis as you progress. You know, the more confident you are, sometimes, you know, you and then you pay the price, because at the end of the procedure you have to spend more time doing hemostasis. So you have to find your tempo. Okay, so the speed of movement of the fiber is another factor that the surgeon manipulates to get the dissection and hemostasis he wants. Okay, so here, as you can see, I'm moving from side to side, trying to get a soft effect. You see the energy is disrupting the fibers that connect the plane with the capsule with the adenoma. This is a beautiful sign of that we are getting to the bladder entry, but I want to finish the dissection laterally on this side. I worked more on the other side, and I would like to have a freer, you know, adenoma on the sides before I open the bladder. If you think about it now, the irrigation, and here's what you shouldn't do, or you see, you shouldn't create a new line. You know, here I was cutting on the adenoma on purpose to show my colleague, you know, what can happen when you're learning. You know, you lose your plane and then you start having 4 or 5 lines. So try to take care of your line. You know, try to stay on the line so that you can progress, and you will always have a beautiful reference of where you are. You see here, sometimes you think, well, I'm getting deeper than I would want. But as you will see, if you have a good control of the working distance, you have a good control of the speed of movement of the fiber, and then, of course, the third factor related to the surgeon, which is paramount, is the targeting. Where you fire your laser in relation to the line of dissection is fundamental to dissect safely. Okay, so if the distance you choose produces a soft effect, you see it's not a very disruptive effect. This is a little bit of adenoma, probably a small nodule that I want to take out. So I'm correcting, you see. I'm not afraid of going close to a very thin capsule because, as I said, I am trying to be extremely careful using the energy so it does a soft effect. You see, it's not very disruptive. If we open a hole in the capsule, it's going to be a very small hole. Remember, the fiber measures 0.5 millimeter. So, and also, you see, I try to move the fiber with a speed that allows me to have this, blowing effect. This is like, if I was blowing against the fibers and this air coming out of the fiber was separating the plane, something like that. So you want this smooth effect because the smooth effect allows you to control really well, the depth of the dissection and the effects of the laser. Of course, here now we have to continue with the connection. That's a nodule, you see, that's a nodule. So I go outside to get it, but I keep very close to the nodule with my fiber so that the energy is mostly absorbed by the nodule, not by the capsule, you see. So if you master these three factors, the working distance, movement of the fiber, the speed of the movement of the fiber, and you target the laser, because if you think about it now, the capsule is starting to get perpendicular to the fiber. So when that happens, you start to fire closer to the adenoma. I put the example of the motorbike driver. When he takes a curve, he has to tilt his body and the motorbike against the curve, and here, when you want to take the curve with the fiber, you have to start firing more close to the adenoma. If you can, while before we enter the bladder, we have excellent irrigation of the space that we are developing and excellent visibility. So it's not a bad idea to check a little bit your hemostasis before entering the bladder, because if there's blood in the medium, in the water, and the bladder is open, then the blood will enter the bladder and then it will be more difficult to wash out. So just check your hemostasis and check your lines. It's very nice when you have a nice line, but as you progress, often the lines get a little bit distorted, and then you have to try to keep constructing them, so you get your life easier. You make your life easier for the following steps rather than more difficult. So that's, again, you see, very softly, very carefully, trying to come up some hemostasis as we go. And then, you see that the fiber is broken. There's it's not a regular surface, I think. But with Holmium, the fiber breaks a lot, and sometimes that can affect the quality of the beam. But of course, we cannot stop every 3, 4, 5 minutes to cut the fiber again and to have a very beautiful beam. So we have to work with what we have. So mostly I cut the fiber when I see that, the beam is not helping me, or it's making my life very hard. But I try to adapt a little bit to the beam that I get, because otherwise it would be, too slow. And you will see that this prostate the whole procedure, the whole HoLEP will take about 40 minutes. And this is quite standard, for this prostatic size. Sometimes we do faster, sometimes a little less fast. Depends also on the quality of the morcellation. But This en bloc technique has one feature, I think, that makes it very attractive, and this is that you have good visibility and you can work constantly. You see, there's no need to stop. So we stop very little, and most of the time the procedure is advancing because, every minute things are better than the previous minute. So, of course, we can do some pausing time, but it's really minimal pausing time. So the operating time is used in the dissection rather than in trying to find out where you are and things like that. So here I'm trying to carefully stay in the plane. You see that sometimes visibility is not so good, but if you trust your movements, then with practice you can continue moving and you know where you are. Exactly as it happened with TURP. Sometimes visibility was compromised and you would cut because you would know where you were. Huh? So here, this is the bladder neck on the other side. So I try to follow the curve, that the fibers, the circular fibers of the bladder neck are showing. Here, the mucosa, Holmium laser is very explosive in nature, and which means that it makes a disruptive dissection rather than a clean cut. And when you come to the mucosa, often the mucosal vessels are opened and there could be mucosal bleeding. So you can, as you cut it, you can spend a little bit of time trying to coagulate, or you can remember to coagulate the mucosa before moving on to morcellation, because otherwise you will have trouble with visibility during morcellation. And many times these are the vessels that bother you with visibility with morcellation. So here again, you see I'm doing now more of the posterior line, and I'm trying to connect the dots. You see, I'm trying to connect the lines. I'm trying to see where I'm going. Here, maybe I was going a little bit into the capsule, but now we are correcting. It's always like that. Huh? You have to correct if you find out that you're going too deep. And if you go into the adenoma, then you have to correct as well. So the thing is that you work in a way that allows you to correct before it's too late. You know what I mean? So if you do a dissection that has a soft effect and you don't deepen too much, you're not very brusque, and reckless doing the dissection, then when you see that you're getting into the capsule, you have time to correct, and that's the key. Trying to avoid. I tend to say small perforations are allowed. What is not allowed is to make a big one. So just continue with your dissection. Try to focus on keeping your lines recognizable, so you can go from side to side. That is a small nodule, and again, you see, I try to remove that tissue if I can. I'm not afraid to test, a little bit deeper, because I know that if I am going too deep, then I will have time to correct, and this is the key to this procedure. You see, constant advancement in the operation. Don't lose time. Try to work not necessarily fast, but constant. And if you constantly can push the operation forward, and I have to say that doing hemostasis is a very good idea because it saves you time. Most of the times, all the time that you spend doing hemostasis during the enucleation phase tend to be time saving at the end, because when you finish, you carried better hemostasis, and then you can morcellate, right away, almost right away after finishing the enucleation. And here again, you see that there's some tissue that looks adenomatous, so I'm going to try to take it out. Sometimes I make a mistake, and what I see as adenomatous tissue is a little bit of the capsule, but you can also vaporize small amounts of tissue if you want. This laser has some vaporization effect. So for minimal pieces of tissue, you can probably vaporize them. And here, when you're under the adenoma, here's where you have to be extremely careful, trying to keep the fiber anterior to avoid firing against the capsule and deepening in the capsule, because now the capsule is almost perpendicular to the fiber. So if you choose to use a very soft effect like this one, you see a very soft effect that develops the plane but doesn't go too deep, you can probably let's check the UO. There it is. There's a funny little calcification near the UO, but I judged in this 85-year-old man probably it's not significant. We will keep an eye on him, but it didn't look very bad to me, and I decided not to touch and not to biopsy so close to the UO. The fact that it is bilateral and near the UOs, it didn't look like a tumor problem to me. It looked more like probably some kind of maybe during micturition the UOs were contacting with the lobe or something like that. So here you see I'm firing up, you see, upwards, remaining very close to the adenoma, remaining and trying to cut some of the fibers superficially. At the end, you have so much control, that it allows you to work with great safety. Here, usually, here I'm lifting the lobe and pushing it in, you see, so the prostate is rotated a little bit, and that gives me a lot of space to see, the final fibers attachments of the adenoma at 6 o'clock. That's the UO there on this side. And the funny little bump with some calcifications. That looks more irritative to me than anything else. And some more hemostasis. Before cutting the last attachments, following the smile, line. It's like a smile following the curvature of the bladder neck. And well, this is almost the end of the enucleation. It's really a piece of cake. As we normally schedule 5 or 6, lately 6 cases in one session, evening or afternoon session. We start up around 3 p.m. and we tend to finish around 9 p.m., something like that. So basically, we can typically do 1 case per hour, which means that the operation takes 30, 40, 45 minutes. And then we try to be very fast doing the changes. This UO was a little bit hidden there, and I was looking at it. So you have to be careful at the end when you're cutting the attachments to try to visualize the UO. There it is, very, very close, and to protect it so it is not hurt by the laser. There we are. That is the final attachment being cut. And now I will spend some minutes perfecting the hemostasis. As you can see, this idea of not looking for the beautiful plane, but just, recognizing the capsule, maybe we can go sometimes a little bit deeper than if you, were to remain in the perfect plane and but this is a distended fossa. When you stop the pressure in the bladder, this will all collapse. And clinically, we remove the catheter the next morning. Patients do really well. So, as I said, maybe sometimes we go somewhat, deeper in the peripheral zone in some cases. But the thing is, if you don't perforate, it really doesn't matter too much. And sometimes I think the prostate is like an onion. Sometimes you can find several planes that are very close to each other. It's like, so you find a plane and then 1 millimeter less deep, there's could be another plane, and then 1 millimeter deeper, there's even another plane that you could be developing. So, yeah, this is how I do it. I look for the characteristics of the capsule that tells me this is capsule. I'm not leaving adenoma behind. Maybe sometimes I'm taking a little bit of the capsule of the peripheral zone tissue, but here we are. That's a line that I marked, perfectly respected. The mucosa is perfectly circumferentially covering the sphincter, so I know this patient will be perfectly continent after the operation. In terms of sphincteric function, of course, sometimes patients can have a little bit of urgency, and if they had urgency before the operation, it's likely that they will have it for a couple of months or 3 months after. But they will get better, but they're not leaking, when standing or walking or coughing or sneezing or something like that. So they're usually very happy patients, especially when they're very obstructed. All these catheterized patients, they're super happy that the catheter can be removed the next morning. And it's really a joy to do HoLEP. I think when you start doing it, you start loving it so much, and there's a positive feedback by your patients. The rate of complications is low. When there are complications, they're relatively easy to manage. I would say that bladder neck stricture can happen sometimes, but when it happens, we do a bladder neck incision and corticoid injection under sedation. So I try to minimize, this to the patient and say, okay, if you had a colonoscopy, it would be just a sedation, and we're going to do something like that just to check that the bladder neck opens. And I recently heard from Marek Sawatki, the Polish urologist who does a lot of stones and HoLEP, that in his experience, these bladder neck strictures don't tend to recur, and I think it's true. I in my experience, it's quite hard to see a recurrent bladder neck stricture. When they have a bladder neck stricture and you do an incision, then they tend to get better. So this is now 32 minutes from the beginning of the operation, so it was a relatively nice procedure. Sometimes I rush the procedures a little bit more, and then they're not so pretty, they're not so nice to see because it's going very fast, and maybe it's not so educational as we're trying to let's say progress in the lists that we do. But I was with my colleague. It was the last case of the day, and we were enjoying discussing the subtleties of HoLEP. And this is now the morcellation. This is the piranha system, and here I'm trying to keep the blade a little bit inside so I can see these black triangles around the blade. That will help me be sure that I'm not close to the bladder. Okay, so morcellation also has improved a lot, and it's only in the very, very large glands when we do more than 200 grams where it becomes a little bit tedious. It takes a little bit longer. But in general, it's a relatively fast part of the operation for the average prostatic sizes, which in our hands, I think it's about 65, 75 gram prostates on average. So this is it. I hope you enjoyed the case. I can see that HoLEP is becoming more and more popular. There's more and more people doing Holmium and other lasers enucleation. I still think that the distinctive advantage of Holmium is that the peak power of this laser opens up the plane better than the other lasers. The thulium fiber laser and the thulium pulsed lasers do not have this feature that I find very nice and very reassuring. And but they have other features. They probably the hemostasis of these lasers is even better than what we get with pulse modulated Holmium lasers. But maybe the plane is a little bit more difficult to follow with these lasers who have such good cutting properties, but not so high peak power that doesn't open the plane through the path of least resistance, which is the interface between the capsule and the adenoma. So yeah, it's very interesting to see the interest. I get a lot of emails and people writing me, reassuring me, and thanking for these videos that are, they say, reassuring for them that they can learn, and of course they can, and they're happy after some time. And yeah, I think these subtle concepts that I'm discussing are paramount. Sometimes it's difficult to communicate what you know, and but this idea of developing the lines, the lines in the right depth, and then once you have a circumferential line around the adenoma, just follow this depth towards the bladder neck, carefully, aiming your laser, depending on what you find, so you don't go into the adenoma and you don't go into the capsule. I think it's a concept that probably it's going to be also very relevant for the new lasers, for TFL and pulsed thulium lasers, because you can orient yourself very well. You can have orientation with this, following these ideas. If you understand this concept of the lines and the development of the lines and connecting the lines, the posterior with the lateral with the anterior, and I think bloc is also gaining adepts. More and more people are starting to see that bloc is a very nice approach. Also, the delimitation of the interface between the sphincter and the adenoma, the white line, the protection of the mucosa, these are concepts that slowly are becoming more and more acknowledged. And of course, people can see in their experience when they start applying these principles, they don't see stress incontinence if they used to have before. So that's a very welcome change. And also the bloc is fast. One of my colleagues started doing a 3-lobe technique despite my insistence, but he joined me in Bulgaria to see a session. We saw 25 cases there, and he started applying the method and the bloc technique, and his surgical times were shortened so much that instead of doing 2 cases in the normal list, he could do 4. So now he's defending bloc as well, and also he values that when the sphincter is released, you relax a lot. So it's more relaxing to release the sphincter early and know that this patient will have a almost 0 chance of incontinence after the operation. And this is morcellation in progress. I tend to keep the blade in a safety position, what we usually say in the center of the bladder, far away from the bladder wall. It's not the center of the bladder, but it would be more or less the center of the opening in the bladder neck, maybe 1 or 2 centimeters inside the bladder. This is the safe position. I like to see the piece dancing, moving from side to side. If you don't see the mouth of the blade, that's a good sign that morcellation is efficient. And also it's a good sign that there's not much water coming out. So you can confidently keep pushing the pedal and confidently moving forward with the enucleation. Here, this is the thing. The morcellator can, despite we throw one piece into the bladder, the morcellator can cut it into many pieces. So often we see that there is a lot of nodules that have been selectively cut away from the big piece of adenoma. I tend to say that the adenoma is like a peach. You know, if you have a harder nodule, the morcellator will eat the meat around, but it will respect the nodule, and then you will be left with these beach balls at the end. You know, the harder nodules that sometimes take a little bit more time to morcellate. And here you see I'm playing the catch and morcellate. You see I go near the bladder and then I lower my hand so the tip of the morcellator goes up. You see here I go down to pick the piece with the suction pedal only. And then before I activate morcellation, I lower my hand so the tip of the morcellator goes up. Of course, don't lower your hand so much that you get up to the bladder neck on the other side, because you could be, inadvertently morcellate around against the bladder neck. So thank you for your attention. I hope you enjoyed the video. I hope to be able to post some more. All the best to everyone.